Hi, everybody. My name is Mahdis Kamali, and I'm a second year PhD student in the HRM program. And today I'm going to be talking about the determinants of mental health service use among youth in Ontario. So just a bit of background. Currently and unfortunately in Ontario, the prevalence of any mental health disorder among children and youth aged 4 to 17 is at an all-time high. It's between 18 to 22%. And of those with mental health disorders, only 26% of children and 34% of youth have made contacts with mental health providers. And mental health service use is shown to be even lower in children and youth from immigrant backgrounds, which is defined as being born outside of Canada or having at least one foreign-born parent. And this same trend is seen in systematic reviews across the globe as well, where children and youth from immigrant and refugee families exhibit lower levels of mental health service use. However, this comes as no surprise, as migration does often fuel health inequities by exposing individuals to economic decline, limited access to healthcare and education, and poor living and work conditions. So while we know that mental health service use is low in children and youth in Ontario, and even lower in migrant children, the mechanisms that are causing these differences are not well known. So, and currently in Canada, much of the research relies on administrative data. So this is more physician-based services from primary care units, hospitalizations, emergency department visits, and these data are being used to guide decisions, and data from psychology services within the community, mental health agencies, and schools is being neglected. So this study will try to fill that gap by using a large representative survey of children and youth in Ontario and employ statistical techniques to firstly identify the determinants of mental health service use, and then also to see whether the service use varies as a function of various factors. So to answer these research objectives, I used the 2014 Ontario Child Health Study, or OAKS, and it's a general population cross-sectional survey of child mental disorders across the province, and it's linked to administrative data. So the target population was children and youth aged 4 to 17, and the sampling frame that was used was the 2014 Canada Child Tax Benefit, and this was used to identify households that occupied children aged 4 to 17, and then these were randomly sampled. And the sampling was actually done in 3 stages. So census tract and dissemination areas were used first to stratify primary sampling units by residency, so urban, rural, and then this was cross-classified by income. So this stratified cluster design allowed for a robust sample that was representative of all of Ontario. And the response rate was 51%, which yielded over 10,000 children and youth aged 4 to 17 across the province. And this survey was done in collaboration with Statistics Canada. So for that reason, the data set is stored at the research data centers. So to access the data set, you have to have special permission. And we do have an RDC center at McMaster. So that's where I've been working on this project. So I used both Bronfenbrenner's ecological model and Anderson's behavioral model as a theoretical basis to conceptualize the characteristics that might drive health service use. So Bronfenbrenner theorizes that child development is influenced by a complex system at the individual, community, and social level. And Anderson's behavioral model believes that the pathway to use health services begins with predisposing characteristics at the individual level, and then community and enabling resources must be present for someone to seek services. So I did a literature review to get a better sense of what are some known predictors of mental health service use, and then I cross-referenced these with the variables in the OAKS dataset and developed this conceptual framework. So not all the variables are listed here, but I will discuss them a little further when I go through the results. So in terms of the analysis, the outcome of interest for this study was defined as any child or youth that has made any contact with a service provider for mental health concerns in the last 6 months. So this was assessed by both provider type and setting. Provider types could have been mental health providers like psychiatrists, psychologists, social workers. They could have been general health providers like family doctors, pediatricians, nurses. or a combination of complementary and alternative medicine providers, so religious or spiritual leaders, alternative healers like naturopaths, herbalists. And then settings could include walk-in clinics, urgent care, hospital, mental health agency, or school. So if a child spoke to any of those providers or accessed care in any of those settings for mental health concerns, it was coded as them having made contact with a service provider. And in terms of the sample, each child in the sample had multiple informants. So they had the person most knowledgeable, that person's spouse, the youth themselves, if they were aged 12 and up, and their teacher. But for the purpose of this analysis, I use the person most knowledgeable questionnaire, which 98% of the time was a parent. And I restricted the sample to complete case analysis across all the study variables, which gave me a sample size of just over 9,000. And for the analysis, I conducted a multi-level binary logistic regression. And as I've mentioned, the 2014 OAKS is based on a complex sample design with stratification, multi-stage selection, clustering, and these can all lead to data dependencies and unequal probabilities of households being selected, which ultimately results in a less precise estimate. And this loss of precision or survey design effect had to be circumvented. So to do this, Statistics Canada developed generalized bootstrap weights. And so it was a total of 1,000 mean bootstrap weights that were generated, and each was formed from 25 regular bootstrap weights. So I applied these weights to the analysis with an adjustment factor of 5 so that we could obtain accurate standard errors. And StatsCan also created survey weights to generate estimates that are representative of the target population of children and youth. So I applied the selected child and sibling weight to the analysis. So as I've mentioned, since the project is at a secure space at the RDC, and StatsCan has strict data disclosure agreements, so I'm not able to show the descriptive information of the sample of the analysis, but this is the characteristics of the entire sample, which is publicly available. So I won't go into too much detail, but just to say that there were 484 neighborhoods across Ontario that were included, and that resulted in, and within those neighborhoods, 6,537 households were selected and 10,000 children and youth within those households. So both a child and their siblings were included in the study. So to go into the results, I know it's a lot here, but I'll kind of just discuss the most interesting and important ones. At the neighborhood level, the only variable that seems to be associated with service contact is neighborhood problems, but the direction is actually interesting. So neighborhoods that have more problems and less safety have higher odds of mental health service contact. And at the family level, families with two parents, so that means one is biological and the other could be a step parent or a foster parent, and single parent households were significantly more likely to make contact with service providers compared to families with two biological parents. And that might seem counterintuitive or the opposite of what you'd expect, but literature actually suggests that families that are going through a divorce or any kind of family disturbance are more likely to seek services because they're aware of that need. So that is something interesting to look into. And then I'll just go to the next slide. And parents that have experienced perceived discrimination because of their ethnicity, culture, race, religion are significantly less likely to make contact with a mental health service provider. And in terms of area of residence, those families living in urban areas are more likely to make contact with a service provider. Parents who have had a previous mental health disorder or diagnosis are much more likely to make service contact, and similarly those with depressive symptoms. And I know the odds ratios might not seem that way, but the scale is actually reverse coded, so lower number indicates more depressive symptoms. And finally, and most interestingly, parents, compared to parents who are born in Canada, immigrant and refugee parents have lower odds of making service contact. And at the child level, children whose parents have talked to or seen someone from the Children's Aid Society about the child are 4 times more likely to make contact with a provider. And this could be because they've already been exposed to accessing care. And similarly, children with long-term conditions and developmental conditions are more likely to seek service. Children with some mental health concerns, so internalizing and externalizing symptoms, are more likely to seek service. And interestingly, positive parenting is not associated with service contact, but negative is. So children who experience harsher or more hostile parenting are less likely to see a service provider. So overall, this study so far has used a comprehensive data set to show the factors that contribute to inequities in mental health service use at the neighborhood, family, and individual level. However, there is some work that still needs to be done. So as a next step, I'd like to look at some effect modifiers, specifically the immigrant status. So to see if the magnitude of the association would differ when looking at something like immigrant status. So it'd be interesting to see whether immigrant girls are more likely to seek services than immigrant boys. And in this analysis, I combined any type of mental health service contact as my outcome, but I think it would be worthwhile to kind of tease this apart and look at the location of the services and also the type of provider used. And of course, I'd like to eventually finalize the analysis, prepare it for publication. And ultimately, with Canada's changing population landscape, I think knowing these determinants that contribute to inequities is very helpful, and we can implement targeted policies to kind of overcome some barriers in access and achieve equitable mental health care and hopefully earlier access to care. So thank you very much, and I'm happy to take any questions.